nice session in the morning. So this is the second session of the morning. We will focus on HCC in this session. And we have multidisciplinary chairpersons here. I am a gastroenterologist who is interested in liver disease. We have transplant surgeon here, Deniz Balcı. And we have also interventional radiologist Bora Peynircioğlu with us today. So HCC care needs a multidisciplinary team, and we have speakers. We have Pierre Golam from Case Western University, who is also the director of multidisciplinary hepatobiliary tumor board at University Hospitals of Cleveland. I would like to invite him while starting the session. So, yeah.
Thank you.
Thank
you. It's a pleasure to be here. Let's see here. So it's a pleasure to be here. Thank you to the organizers for inviting me to this beautiful city. So 2 weeks ago, I was at the big GI cancer meeting in San Francisco, and the view from my hotel was a dumpster in the middle of a parking lot. And yesterday, I looked outside my balcony, and I saw this, and I thought, wow, definitely an upgrade, for sure. I'm thrilled to be here in this beautiful city, and hopefully we can have a meaningful exchange about HCC, the complexities of treating this today, and specifically look at the new data that were reported at the liver meeting. So before I do this, though, just sort of a story that crystallizes where we've come in the last 20 years. So in 2009, as a young and foolish attending physician, I went to the director of our NCI-designated comprehensive cancer center, and I said, you know, there's a lot of HCC out there. We really need a dedicated team and tumor board. And he said, I don't understand why you're here. A, you're not a cancer doctor. You're not a medical oncologist. And B, there's nothing I can't do for someone with advanced HCC other than a morphine drip. And in 2009, that was actually probably true. But I would like to submit to you that we've come a long way since then. And some of the data from the liver meeting very much reflect that. There were a total of about 4,600 abstracts at the liver meeting, and of those, 261, that's down from before, were actually specifically related to hepatobiliary neoplasia. Most of these are HCC. I'm actually giving a second talk on cholangiocarcinoma, and that's a sliver of those, only about 25, 30 abstracts. There are always dedicated plenaries, transplant plenaries at the meeting, so there's a lot of late breakers and plenary talks, and we'll get to those in a second. And the general themes, which are actually highlighted in this graph that gives each theme an outsized importance depending on how frequently it was discussed, as you can see, are treatment, survival, therapy, and response. And that pretty much is what we're going to be talking about today. So to sum up, we are going to start by discussing epidemiology and biology. We're going then to talk about people at risk and how we might be able to not only treat them, but also screen and diagnose them. And last but not least, we'll talk about therapeutic strategies, and hopefully in the case discussions, we'll have more dialogue about systemic therapy today. Let's start with some epidemiology and biology data. So, the global burden of liver cancer has been fairly actively debated for the past few years. So one of the important points to understand is whether we're actually seeing more liver cancer over time or not. And a paper in 2023 by Dr. Younasi and colleagues seemed to reflect that the annual percent change in liver cancer seems to be trending favorably, as in we are seeing less liver cancer. This is another effort to sort of look at primary liver cancer incidence and mortality and forecast this for the next 25 years. So if you look at the forecasted period of time between 2021 and 2050, it is anticipated that primary liver cancer will probably decline at an annual percentage difference of about minus 1.1%. So every year you're going to have a decline of about 1.1% over time, which means that in 25 years you'll have an about 25% decline. That's pretty significant, right? And there's another assessment here that basically reflects very similar numbers. Note that HCV, which we are going to be eradicating in many parts of the world, probably the United States will be the last country to eradicate hepatitis C, but in many places that's already happened, Egypt, Georgia, Australia, the EU. That's going to go way down. Hepatitis B, we're going to be achieving virological cure, better control, probably also going to go down. The only sliver of incidence that's going to go up is with MASLD, and that's also going to drive mortality. And the only part of the world that's probably going to drive the incidence up is, again, the Americas. So that's an important point to remember. So generally, there's going to be a global decrease in primary liver cancer, and there's going to be an increase in MASLD-related incidence and mortality in the Americas. The second abstract that I wanted to highlight is actually somewhat of a basic science effort, but it makes intuitive sense for anyone who treats HCC. So the liver's metabolic and regenerative functions are actually very much spatially related, right? You remember, we all remember and teach our trainees that there are different zones in the liver, right? Zone 1, Zone 2, and Zone 3. Zone 1 is the closest to the portal vein, and Zone 3 is the closest to the central vein, where there's more ischemia and potentially more potential for injury. And in fact, there is a polymorphism of ZNRF3, RNF43, which is one of the regulators of one of the main drivers of liver cancer, which is the beta-catenin pathway. And that in turn actually disrupts these spatial transcriptomics. And in fact, if you actually see this, and you study this in mice, you can easily see how the disruption of this in the setting of chronic liver disease creates an environment where you're much more likely to actually have disruption of the beta-catenin pathway, and therefore the development of cancer in the setting of this potential polymorphism. There are really no therapeutic implications of this at the current time, but who knows? We might be able to understand this better in years to come. I did not actually intend for these slides to actually come up one click at a time, but for some reason the PowerPoint software changed that, so I apologize for that. I'm going to try to just click on all of it so you can see the whole slide. The second part of this is disease risk. I'm going to go from steatosis to stiffness and how this might in turn correlate with signal of cancer risk. So we know that MRE is a very good assessment of liver stiffness. We've heard plenty of talks this morning and yesterday that reflect this, but might it also be a very good way to predict an increased risk of liver cancer? And this is very much what this fairly large cohort from a single center of about 2,000 patients was trying to see. So let's look at HCC surveillance as we have it today, which is an ultrasound or cross-sectional imaging every 3 to 6 months versus potentially patients who have undergone an MRE. And lo and behold, of course, MRE predicts mortality pretty well, especially if your cutoff is greater than 5.3. We know your risk of decompensation and your risk of dying is increased. But not expectedly necessarily, your actually risk of HCC is, in terms of an adjusted hazard ratio, just as robust, right? And in fact, if you look at adjusted hazard ratios for a cutoff of 3.62 versus less than 3.62, it's even more robust, right? More predictive of HCC. This comes on the heels of data from all over the world now showing that spleen stiffness is actually a very good predictor of increased risk of HCC. And I bet you at the Baveno meeting in not even a month from now, this will in some ways percolate into the final manuscript and the recommendations that the Baveno group will will formulate. The next abstract that I'd like to discuss is hepatic steatosis and metabolic dysfunction and how this affects the treatment outcomes in HCC. There's actually a long history of this, a long background. So back in 2022, there was a paper in Nature by the Heidelberg group that basically suggested that if you happen to have MASH, you not only have an increased risk of developing HCC, even in the absence of advanced fibrosis, you also are less likely to respond to therapy, specifically immunotherapy. And one of the theories about this is that this happens because you have exhaustion of PD-1 positive, CD8 and CD4 positive T cells. So you're actually reducing your you're dampening your immune response that's basically triggered by immunotherapy if you happen to have steatosis. This is sort of a clinical attempt to try to replicate this or understand this better. This was a prospective cohort of about 209 patients. All of these patients had HCC. They had steatosis, which they measured by MRI-PDFF, a CAP, or of course a biopsy, and there were cardiometabolic risk factors, which you are all familiar with: diabetes, obesity, and hypertension. And they assessed the response by what we call the LIRAT system, which is an objective system that measures probability of having cancer, and also what we call MRECIST, which is an assessment of change in the size of a tumor, which tells us whether the patient had a complete response, a partial response, or no response. And this is basically what this showed. Not surprisingly, a higher steatosis actually was associated with a more advanced stage. We know that this is true. We've known that this is true for a few years now. But I think somewhat concerningly also, among patients who are receiving treatment, specifically here local regional therapy, patients who had cardiometabolic risk factors actually had a lower response. So this doesn't seem to apply only to systemic therapy, doesn't only apply to immunotherapy. It potentially applies to catheter-mediated treatments like ablative therapies and potentially radioembolization or chemoembolization. There's also an interesting, and I have to say unexpected finding in that fat fraction specifically predicted poor response. So might we in the future be using MRI-PDFF for purposes other than to stratify steatohepatitis or steatosis? Who knows? There's a not very attractive name for this that was generated from the paper. It's called the CRAFPIT score, and it incorporates a bunch of inflammatory markers, and these predict accuracy for treatment response with a very good area under the curve of 0.92. So the bottom line is metabolic dysfunction and hepatic steatosis not only associated with more HCC, also associated with poorer treatment response. Moving on to screening and diagnosis, this is really the Achilles heel of our field. We do not have great ways to screen for HCC, and we have even poorer ways to survey for it. And one of the major efforts in this field right now is to actually find better ways, simpler ways, more sensitive and specific ways to screen people at risk for HCC. This is, I think, the probably 20th paper that shows exactly the same thing. This has been done in the VA system. It's been done in federally qualified health centers, which are centers that care for persons who have psychosocial or economic disadvantages in the US. It's been done in Europe. It's been done all over the world. We have guidance for screening for HCC, which include an imaging study, typically an ultrasound plus or minus AFP. We've now aligned as saying that an AFP is actually useful. Yet this remains very underutilized, and this indeed is an attempt to understand how underutilized this is. How likely are patients to undergo complete screening with a 6-monthly HCC surveillance? And if they are not, why is this not happening? So this is a 3-year prospective cohort of persons with cirrhosis. This excluded patients with pre-existing liver lesions. Of course, we want to screen patients who are at risk but don't already have liver cancer, and there were a number of parameters recorded, including, of course, adherence and self-reports. And if you look at full adherence, meaning the patient, like clockwork, is getting an ultrasound and an AFP every 6 months, that's right, 9.1%. 73 out of 800 people get, I'm sure this many folks are nodding in the audience, this is very much your experience too. And if you look at the somewhat okay path where you're only getting an ultrasound, that's still under 50%. So why are people not getting their appropriate surveillance? This, again, is a recurrent theme, not being advised by a treating doctor. I would submit to you that if you're a gastroenterologist or a hepatologist, you're probably telling your patient that they should be screened and surveyed. But of course, the bulk of the patient's care, if they don't have very advanced liver disease, is in their PCP, in their primary care practice doctor, and that person may not have the same awareness of this as everybody else. Ultrasound is expensive. In the US, you incur a copay every time you get an ultrasound, so there's a financial constraint. There's an access constraint. It's an asymptomatic disease, right? You're not having symptoms when you don't have liver cancer, and if you have compensated cirrhosis, you may not have much in terms of symptoms, so you may not feel a need to actually be screened and surveyed. This is a real problem and certainly something that needs to be addressed meaningfully in the future. So to sum up, 1 in every 10 patients only adhere fully to HCC surveillance protocols. So what can we do to actually make this better? It is my conviction and the conviction of many people in our field that the only way to make this better is to make it simpler. And the only way to make it simpler is to get rid of ultrasound. You have to get rid of ultrasound and make this a blood-based screening and surveillance strategy. And there are many efforts to actually make this happen, the largest of which is the study called TRACER, which we are part of. TRACER is a 11,000-person randomized trial of this blood test called GALAD, which includes 3 components: AFP, the L3 fraction of AFP, and DCP, also known as PIVKA2. And there's a composite testing of this, which is commercially available already in the US, versus current standard of care, which is ultrasound with AFP. We've accrued about 5,300 patients last time I checked my email, so we're halfway there. And this will be 5 years in the making before we have conclusive data. But this is basically the basis of why we think this may be a good test. So we're comparing different models: GALAD, GAP, ASAP, and AMAP. These are all either a full sequence of GALAD or abbreviated components of the test versus the standard, which is ultrasound and AFP, and looking at this over time. And without getting into too much detail, I will say this: GALAD, ASAP, and GAP all outperform traditional biomarkers, individual biomarkers, and GALAD specifically offered the most consistent diagnostic accuracy across different cutoff strategies. And this was actually quite true in the setting of non-viral and early-stage HCC. Non-viral hepatitis, of course, aka MASH and alcohol-associated liver disease, are particularly challenging because oftentimes the increased echogenicity and density in the liver make it harder to pick up small cancers. So this may be of even incremental benefit in that subset of patients. What about other strategies? Can we actually leverage epigenetic tests, which are a blood-based test, to actually look at this? And this was a late breaker abstract by our good friend Binu John, and basically the premise here, again, is ultrasound. Not only people don't want to do it, but it also has low sensitivity for early stage HCC. There is already a commercially available methylated multi-platform blood test that's called OncoGuard, and this basically combines different DNA methylation markers with AFP, and how might that actually increment the ability of an abdominal ultrasound for early stage HCC detection? And so this basically was done in combination with an ultrasound within 90 days, and there was diagnostic confirmation of HCC whenever that was suspected. And this essentially shows you, and it's, I don't know if you can see this clearly, but the The multi-platform HBT test, the OncoGuard test, is shown in the blue bars, and clearly your ability to pick up on early stage in general is actually seems to be quite superior detection compared to ultrasound, and the specificity is actually largely the same. So potentially one might be able to increment sensitivity and not compromise too much specificity when using the simpler blood test versus ultrasound. That's certainly another sound strategy to potentially get rid of ultrasound and makes screening and surveillance simpler. Let's actually look at another abstract by Dr. Parikh and colleagues, basically looking at a different test. This one is a cell-free DNA test. I don't know if there are any medical oncologists in the room, but if there are, you already use this test to basically test patients for what we call minimal residual disease. That's when somebody has cancer treated or resected, and you're trying to monitor them to see if there's any microscopic cancer floating around in the bloodstream. That's what cell-free DNA is basically there for. So could we potentially harness the ability to measure cell-free DNA with methylation profiles to augment or maybe even replace AFP and HCC? These were 135 individuals with HCC and a bunch of other patients at risk, about 167 patients, and there were samples that were primarily biobanked, which included 32 patients at risk. And if you look at the area under the curve for this, it's actually very respectable, certainly seems to augment pretty significantly your ability to pick up compared to AFP. AFP, of course, is in the green lines. Methylation parameters is in red, and methylation and AFP doesn't really increment your ability that much, but certainly is better than AFP alone. How about treatment strategies? So obviously the biggest reason why we don't give people with advanced HCC morphine drips anymore is because we have pretty good treatments for them. In fact, increasingly, we're able to even transplant patients who have HCC that has invaded a large vessel. We can talk about that later, perhaps in the discussion. But this has almost exclusively happened because of the advent of immunotherapy. We now have 3 FDA-approved immunotherapy regimens. The first one was approved in March 2020. That's atezolizumab and bevacizumab. The second one approved in 2023 is durvalumab and tremelimumab, and the third approved just 2 years ago is nivolumab and ipilimumab, and that's definitely something that's allowed patients with metastatic HCC to have a greater than 20% 5-year survival, something that you would not have dreamt of, I would not have dreamt of in 2009 for sure. There are problems with immunotherapy, of course, because you're revving up the immune system, you're eliminating the brakes that enable tumors to escape immune surveillance, and as a result, you just rev up the immune system in general. And if you do that, might you create problems if you're planning to transplant the patient? Because, of course, you might increase the risk of rejection. And the jury is still out on this. I would like to present to you 2 different perspectives, I think both favorable, but to varying extents. One is a study that looks at 375 patients. It's called the LIFT-HCC study, and it's trying to see what happens to patients in whom we give immunotherapy afterwards. Do they develop significant rejection, and what are the underpinnings of that? So to summarize, this was a cohort which basically on the median received 4 cycles of immune checkpoint inhibitors. The median washout, which we think is important, the longer you are away from the last dose of immunotherapy, the better off you are in terms of reducing likelihood of rejection with 72 days. A recurrence happened in 28% of patients, 17%, which are 13 cases, actually had rejection, and 22% over a 1.6-year median follow-up died. The highest predictors of recurrence, not surprisingly, were AFP, HBV etiology, and anything beyond Milan. And the worst overall survival was also in patients who had a high AFP, and those who actually started an immune checkpoint inhibitor less than 20 days before they underwent a transplant. And this just is illustrated here in 1 year and 5 year recurrence-free survival. Notice that excellent recurrence-free survival happens if you're within Milan, 93%. If your AFP is a little bit higher, it's 80%. But if your AFP is high, and you also look at all these patients who have more risk factors, it can be down to 51%. So this suggests that Milan criteria and a low AFP in someone with, who is receiving an ICI can potentially be used to give you an excellent outcome. I'm going to close on this. There is now a fair amount of data from the Checkmate 9 DW trial, the trial that led to the FDA approval of nivolumab and ipilimumab. It basically looks at what these patients did afterwards over time in terms of how their liver function was maintained. And this basically is an important detail because the dose of ipilimumab given here is 3 milligrams per kilo every 3 weeks. That is a high dose. That's the same dose that patients with advanced melanoma get. So this is not a lower dose of immunotherapy that many of us may be familiar with. In the medical oncology world, when people assess liver function, they don't do it with MELD or Child-Pugh score. They like this thing called the ALBI score. The ALBI score is a logarithmic formula of albumin and bilirubin, which I never use, but they are very much in favor of that in order to understand the change in liver function over time. The study was positive. The median overall survival was 24 months versus 20 months for the comparator arm, which was lenvatinib and sorafenib, 2 tyrosine kinase inhibitors. Overall, there was, if anything, a reduction in the risk of hepatic deterioration. To the right, as you can see, are Kaplan-Meier curves, which end up separating in favor of immunotherapy over time. But there is a price to pay, right? 19% of patients develop immune-mediated events, of which 15 were grade 3 to 4. Not shown here, but known to everyone, is that 60% of patients need corticosteroids in order to mitigate these side effects. So to sum up, liver function seems to stay stable over time when you give patients immunotherapy, but there's a price to pay in terms of managing what we call immune-mediated adverse reactions. So to sum up, the global trends suggest that HCC might be declining over time. The only wrinkle here is that MASLD may be driving this up, and that we may be better understanding the underlying pathological and histological changes in terms of spatial transcriptomics that actually lead to HCC becoming more likely in the setting of MASLD. Metabolic dysfunction is probably a predictor of worse outcome in HCC and also a poorer response to treatment. We may be able to harness the agents, the devices that we use to measure stiffness to predict risk of HCC. This includes MRE and potentially spleen stiffness. And real-world adherence to surveillance is dismal, and we need better tools. And we think that next-generation biomarkers and methylation-based blood tests may actually resolve this. Therapeutic strategies are definitely evolving to include immunotherapy and precision genomics, and I think that is very much going to be the way of the future. And with this, I will end, and thank you very much for your attention.
Thank you for the excellent debrief. Do we have any questions from the audience? I have a question. As you mentioned, the Nature study showed that immunotherapy in advanced disease may not working in muscle D HCC compared to HBV HCC. But as you mentioned, in the study that received immunotherapy for downstaging, HBV patients did not better, actually did worse.
Right. That's correct. Yes.
What's the reason behind this discrepancy, in your opinion?
Right. So this is a very controversial topic. The party line, if you talk to folks who do systemic therapy, is that there is no actionable basis for specifically choosing, say, immunotherapy versus a tyrosine kinase inhibitor in the setting of someone who has MASLD versus viral hepatitis. And in fact, if you look at subset analyses in the 3 pivotal trials that led to the FDA approval of durvalumab and tremelimumab specifically, there was actually no difference between patients who had non-viral hepatitis versus those who had viral hepatitis. If you look at the initial approval, which was atezolizumab and bevacizumab, which is a combination of a PD-L1 inhibitor and a VEGF monoclonal antibody, there was a difference in response specifically related to patients with MASLD who had a lower response. But that appears to be mitigated by other confounding factors. So there's been a subset analysis done since then of the same database from this trial called the IMbrave 150, which suggests that that is not probably related specifically to the etiology.
Okay, thank you. Murat?
Thank you, Dr. Golem, for your talk. I wonder how you select the patients for double immunotherapy instead of atezobeva.
This is just generically all patients, not patients who are specifically looking at downstaging for the purposes of transplant. You're just thinking in general. That's a really hard question to answer. We struggle with this every Monday afternoon at Tumor Board. But I will tell you what our general gestalt is. In general, we actually go with atezo-bev based on the level 1 evidence that supports it being a preferred regimen, with notable exceptions. If a patient has a high risk of bleeding that cannot be mitigated, you probably don't want to give them bev. Bev obviously increases your risk of bleeding. Unless you've already mitigated this through endoscopic variceal ligation or other interventions. If you can't mitigate that risk, we would probably not give the patient bev, and we would choose to give them durva-tremi. Durva-tremi, of course, is a course where you only get 1 dose of the CTLA-4 tremi, and then you get durva afterwards. So you're actually not exposing the patient to 2 immunotherapies over time. And nivo-ipi, which is the road less traveled, I'll sum up, is also a priming dose of a number of doses of the CTLA-4, which has high toxicity. That's ipi, and then you continue to give nivo after that. So the toxicity over time, to some extent, is mitigated once you stop giving the CTLA-4 inhibitor.
Is the liver reserve, does the liver reserve affect how you choose your treatment, and how?
Yes, so that's another excellent question. So Nivo-1 Ipi-3 is, I did not have time to show this, but if you look at the Kaplan-Meier survival curve, it is one of the most unique Kaplan-Meier survival curves ever, because initially it looks like the control group is actually better than Nivo-Ipi. And then about 6 months into this, the survival curves cross, and then sort of the phoenix rises from the ashes, and suddenly you're actually getting a better outcome with Nivo-1 Ipi-3. And the reason for this, we think, is that there is an initial period of time where if your liver function is less than optimal, you're basically dying early because of liver disease, not because of your HCC. And so it is generally accepted, though by no means codified, that if a patient has bad liver function, you should probably not be giving them Nivo-1 Ipi-3. That's a really rough regimen because you're giving a high dose of a CTLA-4 inhibitor, and you're much better off giving them durva-tremi or atezo-bev.
Thank you.
Yeah.
Gökhan, before you ask, I would like to continue where Murat has stopped, because I think that it came to an important point. You mentioned the importance of the current immunotherapeutics in the neoadjuvant setting. But as surgeons, we would like to see those patients when they are downstage appropriately.
Right.
And if we can resect them, which will be the ultimate downstaging modality, or transplant them. And how do you decide this?
So there's been a very rapid evolution. So I'm going to, right after this, I'm going to a HCC live meeting, which half of the meeting is going to be talking about exactly what you're referring to. So there's been a very rapid evolution in how we do this. 5 years ago, if I told you that you would have portal vein invasion by tumor, right? So tumor portal vein invasion in a branch, not in the main portal vein or its main branches. So that would be VP1 or VP2. And I offered you a transplant. If you had a complete response, you would think that this was complete insanity. It turns out that many of these patients, I would argue most of these patients, actually do well with transplant. You could resect them too if they are an appropriate candidate for this. And this has largely happened because of immunotherapy. So immunotherapy is safe and potentially effective in those patients. And we don't really understand what percentage truly succeed in getting downstage without dropping out. In the Vitality study, which was published about a year and a half ago, around 60% of patients achieve that, 60 to 65%.
Do you have Cleveland Clinic intention to treat analysis?
So this was basically a case series. This was obviously not a randomized controlled trial, and this was on an intention to treat. This was an intention to treat analysis, correct?
Thank you.
Yeah.
Yeah, the problem here is the same Kaplan-Meier curve. I would try to approach it in an opposite manner because the lines cross each other after like 6 or 10 months. But
4 to 6 months, right?
yes,
Yeah.
and then after 2 years, we can see only a handful of patients remaining in each arms.
Right.
And statistically speaking, this can be create a significance, of course, but
Right.
in the real life, this is very difficult to use in our daily practice yet. This is what keeps my mind busy, and I'm not too much keen on to giving this high side effect treatments to our readily fragile patients.
Right.
What's your opinion?
Let me understand your point just so I can answer the question correctly. You're saying that you would not favor giving immunotherapy in general to a patient or just NIVA1 EP3 specifically?
Ipi-Nivo trial gives very similar results with the previous atezolizumab treatment. The difference comes from very small number of patients after some point of time. If you can show the Kaplan-Meier curve
Right.
again.
Yeah, I think they choose.
Yeah,
so, but I know the data, so I can describe it.
Yeah.
So actually, at 1 year, more than half of the patients are still alive, and actually at 4 years, 28% of patients are still alive. So sure, it's a much smaller number than the sum total, but it's not a minuscule number. To your point, though, with immunotherapy, whether it's for melanoma, whether it's for lung cancer, whether it's for HCC, you always get about 20 to 30% of patients who have what we call durable, robust responses. That's the patient who lives for 8 years or 9 years, right? In colon cancer, in MSI-deficient colon cancer, that is the prototypical patient who we think might be cured with immunotherapy. So yes, there is very much a subset of patients that respond exquisitely well that very heavily drive this. But it is not a minority of patients. I mean, you're talking about a third of the patients. I mean, think about when we had sorafenib in 2007. Your median survival was 9 months, right? We've come a long way if we truly have 20+% of patients that are living five years or more. The point, though, to be made is that it is a harder regimen to give for sure compared to atezo-bev or to durvalumab. So if your patient is not optimally conditioned and has borderline liver function, sure, I wouldn't give them NIVA1 EP3.
Dr. Golan, thank you. Gökhan,
Yep,
thank you.
Mike,
This was
thank
an
you.
excellent discussion, actually. Thank you. So, Dr. Golan can take a rest for his second talk, so we can invite Coşkun Demirtaş to give his speak on multidisciplinary model of care in liver cancer.
Thank you so much. In the second talk of this session, I will try to briefly summarize the modern strategies in the multidisciplinary model of care in liver cancer. So we are dealing with a very heterogeneous disease, right? Because the heterogeneity comes from an individual level, because we are dealing with one patient who has two diseases, usually with a chronic liver disease, and on top of that, they have a tumor that we are trying to treat. And other than the individual level heterogeneity, we are also dealing with a global heterogeneity that different countries or different geographical regions have different etiologies or different surveillance strategies that comes up with different stages at the presentation time. And also, most importantly, that different countries have different access to the treatment availabilities, that not everyone has an easy access to the liver transplantation or the modern immunotherapy combination. So what I'm trying to say is that while doing this multidisciplinary treatment approach, we should individualize these kind of decisions based on the country that we are giving our decision to give an optimal decision for these patients. And while going forward to the decision of these patients, we should have all of these in our hand, starting with high-quality multiphasic imaging that will provide us, that will make us able to calculate the tumor burden in this stage. And we need to know all the details about the liver function beyond Child-Pugh LBM MELT, with all details about the presence of portal hypertension and the prior decompensation. And the next question will be, will our patient be fit for the proposed therapy option? And how about the tumor biology? Did the AFP just increased slowly over a year, or did it just doubled in the last month? And what was the prior treatment, and was there a treatment failure, and what was the reason for that treatment failure? And after knowing all these, that before going forward with the discussion, we should have an idea about if our patient is a candidate for a curative option or a non-curative option, and then we're gonna discuss which treatment option would be better for these patients. And then what you need to do is to get all these specialties that are involved in the management of HCC together, and then we start discussing which option will be better for these patients. So we do not strictly have to adhere to the BCLC guidelines or the other guidelines, but what we are doing in real world is that we are personalizing the treatments, considering the patient heterogeneities. But it's easy to explain things over BCLC guidelines, because when I talk about BCLC stage A or B, that everyone can have an image of these patients. So I'll go forward with the BCLC staging, that when we have a very early or early stage, that is defined as having a single nodal less than 2 centimeters, you all know it very well, or early stage HCC, single nodal, regardless of size, or the up to 3 nodals, each less than 3 centimeters with preserved liver function. So the options here are mainly curative, that we imagine a patient that is a good fit for a curative option for these patients. And the options are preferably the surgical resection. If not a good fit for surgical resection, then we consider ablation, or maybe we should consider this patient for transplantation. So the treatment decision in early stage HCC is, well, we are trying to consider one of these curative options to these patients. And there's a very large gray zone overlap in between these decisions. But usually when we have a single tumor with a preserved liver function with AFP less than 1,000, and if there is no clinically significant portal hypertension, and then we consider surgical resection for these patients if technically feasible, and because it provides the best long-term overall survival. But if we don't think that this patient will be a good fit for surgical resection, mainly could be due to that maybe the minimally invasive procedure would not be that possible, or major hepatectomy is afraid of, and maybe there are signs of clinically significant portal hypertension that we are afraid of the post-hepatectomy liver failure, and in some patients that we consider an alternative curative approach, usually with a percutaneous ablation, either RFA or the microwave ablation, because it provides almost similar overall survival outcomes in those with tumors less than 2 centimeters in comparison to the resection. And it has the advantage of being minimally invasive, and it has acceptable local recurrence rates. But not all tumors are accessible via percutaneous route, so then we consider other alternatives of this alternative curative approach, which is nowadays as more commonly being used in clinical practice. Then we introduce the SBRT option for these patients if it's not technically reachable or due to the location, and maybe sometimes we consider transarterial radioembolization a better option, even within the early stage HCCs, if it's not technically suitable for surgery or an ablation. And when do we consider liver transplantation to these patients is that when we think that the cirrhosis will determine the prognosis of these patients, right? So what we need to do is to treat both the cirrhosis and the tumor, and usually these patients have either portal hypertension with impaired liver function, and some of them have decompensation history, but still has to be suitable for liver transplantation, considering the biology of the tumor and the fitness and the patient-related factors. So how we decide on surgical option in the early stage HCC is like, there's a trend towards favoring liver transplantation with the increasing severity of the liver disease. And if your patient has less severe chronic liver disease with no portal hypertension, then we favor surgical resection for these patients. But usually within the MDT judgments, there's a large overlap area and even some of these patients usually are treated with ablative options after the MDT judgment for these patients. And we are considering all the parameters that including the scarcity of the liver grafts or the availability of the donors or the possibility of a minimally invasive approach, and also considering the patient preference as well. Then let's say we are, with all means that we consider our patient eligible for resection, then what we need to do is again, to perform a multiparametric assessment, including with all details the liver function, then we need to calculate the future liver remnant, and we need to consider the patient-related factors as well. Then we can expect these good outcomes of liver surgery with low mortality, morbidity, and post-hepatectomy liver failure. So Dr. Golham has also mentioned, but nowadays we still do not have convincing evidence to use immunotherapies in the neoadjuvant or adjuvant setting, but I can say that this area is promising and probably going to be evolved in the next few years. Is there a preference over any thermal ablation over the other one? Well, the simple answer is no. The IR can choose RFA or microwave ablation, but we all know that IR people like a microwave ablation more because it's faster and you can have a larger margin, or if there's a perivascular lesion, microwave seems to be a little bit in forward based on the few data. So moving on with the intermediate stage HCC, this is the most heterogeneous gray zone translation zone of the HCC patients, that these patients can be considered for curative options or with the traditional TACE, or some of them are best fit for the systemic therapy. So this is how the modern BCLC management looks nowadays, and even within the BCLC definition, as you can see, more than 3 nodules or up to 3 nodules with at least one of them higher than 3 centimeters. But your patient still has to have a preserved liver function. So within this definition, you can see a patient with a small tumor burden confined to a segment, and then you would think that an aggressive curative approach like liver resection, or maybe you would consider downstaging this patient to a liver transplantation, and your patient would have probably comparable results to a patient with early stage that has been transplanted. Or your patient can present with a bilateral multifocal disease, but you still think that you can control this tumor with local regional therapies, and maybe the combination of these local regional therapies will be best fit for these patients. Or sometimes, without an extrahepatic spread, that there's a high volume, high spread in the tumor, then we think that the local regional control of the tumor within the liver is not very feasible. Then we are trying to preserve the liver function in these patients. So then we may still decide on passing to the early systemic therapy for these patients. So talking about the surgical BCLCB candidates, is that what I'm trying to say is that we are trying to find these patients who will likely benefit from a liver transplantation that are within the expanded criteria, and we are trying to, or some of them can be downstaged regarding the size and the biological values, including the AFP levels, and then after the downstaging, we usually wait for at least 3 months that the AFP levels are not increasing back again. So then this would be a better candidate for liver transplantation. So whatever the expanded criteria that we are using, we should not forget that the further we get from the further the distance from the resectability or the transplantability criteria, the higher the price with lower results. So we are trying to find the best candidates for liver transplantation who would have almost comparable 5-year overall survival in comparison to the early stage HCCs. So if our patient within the intermediate stage is not a good candidate for liver transplantation, not a good fit for the downstaging, then we discuss which local regional therapy is a better fit for our patients. So we have been using traditional TACE over years, but nowadays we're using TARA more and more in the routine clinical practice because there are some data that in large solitary tumor, TARA can be more safe and effective, or if there's an alteration on the portal vein, if there's a portal vein thrombosis, TARA could be a better option for these patients. But we can also use both of them in downstaging and bridging based on the presentation. But if the tumor burden is higher than at least half of the liver, then probably none of these local regional therapies are safe, and we can still consider switching to systemic therapies within BCLCB. But systemic therapies are mainly dedicated to the advanced stage traditionally, and which is defined as any, regardless of the intrahepatic burden, when you have a vascular invasion or an extrahepatic spread, then we are talking about a BCLC stage C that is an advanced stage HCC. So what we have witnessed in the last decade is the evolution of systemic therapies with the revolution of the immunotherapy combinations. And now we have 4 positive phase 3 randomized controlled trials, and we have even more first-line options. We will have more even first-line options in the near future. But this is still how it looks like to manage these advanced stage HCC patients. In these patients, the first question is usually, is there a contraindication to immunotherapy? Is there an autoimmune disorder, or is there a history of a liver transplantation? If yes, then we are going forward with the good old sorafenib or lenvatinib. If there is no contraindication to immunotherapy, then our decision is mainly based on the bleeding risk. If there's a high bleeding risk, then we usually do not select antivascular endothelial growth factor bevacizumab containing regimens. Instead, we can consider tremelimumab, durvalumab, or potentially the other phase 3 positive trials, including nivo-ipilimumab maybe in the future, and the pembrolizumab and rivoracidib. But if there is no risk of bleeding, still, that because it was a landmark study, that there's a trend towards selecting the atezolizumab as a first-line option for these patients. And as you all know, if this is a terminal stage, or if the end-stage liver function, but the patient is not a good candidate for a liver transplantation, then we do not offer any disease-controlling therapy for these patients because we think that it will not determine the patient's prognosis. Instead, we recommend an early palliative care. So an important frequent MDT question, what we discuss in the multidisciplinary discussions, is that how about if we combine the local regional therapies with the systemic therapy options to get a deeper response, especially in those with aggressive biology or those with very high tumor burden, with the price of liver toxicity, the increased liver toxicity, but we didn't know the answers to these yet. But what we have to think about is when we are discussing this is that is this deeper response going to translate into a meaningful survival for our individual patient? So keeping this question in mind, when we have a look at the data, the evolved data, is that the TACE plus TKI combinations have never been able to show that they can improve overall survival. But the TACTICS trial showed us that TACE plus sorafenib can improve the progression-free survival. That means that you can have a better control of the tumor, but the main aim that we are still trying to get, the extension of the overall survival, has not been met. So what is better is the TACE plus immunotherapy combination. So 2025 has been the year of TACE plus immunotherapy combination trials. We have 3 randomized controlled trials that has been released in the last year. So the answer is yes, you can get a better tumor control with improved progression-free survival, but with the price that Dr. Golem has mentioned, with the price of getting a higher adverse events, that could potentially lead to discontinuation of these therapies. But the LEAP-012 study, that is the combination of an immunotherapy, lenvatinib, and TACE, that we are still waiting for the overall survival outcomes for these patients. But we still don't have any improvement in the overall survival with the cumulative literature. So what is more promising in this field is probably the combination of transarterial radioembolization with immunotherapy combinations, because theoretically this would be a safer approach, and the initial phase trials showed promising safety and efficacy signals, but we still have to wait for the ongoing phase 2 randomized controlled trials, and currently we cannot recommend everyone this option, that we are trying to find the best candidates that would benefit from these kind of combination therapies. So, well, in summary, the local regional therapy plus systemic therapies can provide a better tumor control, but we do not know in which patient that will this translate into a meaningful extension of the overall survival. So before getting an answer to that, what we are still doing in clinical practice is that we're trying to personalize these kind of decisions. Usually in the decisions that we come up with is that when we see a targetable lesion in the liver, but with an extension with good preserved liver function, and especially if your patient has a high tumor burden or an aggressive tumor biology. So the HCC management, as you all know, is a dynamic process. Your patient, you can ablate the tumor, you can get the control of the tumor, but your patient can get decompensated. Or your patient can progress, but you can preserve the liver, and that patient can have a much more extended overall survival. So that's what we are trying to find in these patients. What we are doing after resection or ablation or curative options is like we are following these patients for recurrence, and we treat it according to the recurrence presentation with the appropriate therapy. And it's almost similar with the local regional therapy, but we are trying to avoid repetitive, ineffective therapies. Let's say if you try TACE more than 2 times and then you still cannot get a result, you should turn back and discuss back with maybe just switching to another strategy. But what requires mentioning is the strategy after systemic therapy, because it's usually the last stop for these patients. So let's say we started a first-line therapy for these patients, and if they are regressed or stable, then there is no problem. But if you go on with that therapy, but if there's a progression, that we are out of options right now. So if the progression is within liver, and if it's targetable, usually the approach is to go on with the first-line therapy, but just treat the oligoprogression within the liver if we think that it is targetable. But if there is a multifocal extrahepatic, or if you think that the liver functions are at risk, then we should switch to the second line at these patients. So what we are trying to do in multidisciplinary management of HCC is that regardless of the size, we are trying to find the good candidates, best fit patients for curative options. And again, regardless of the size, that we are trying to find the patients that will not benefit from curative options. Instead, with a disease control strategy, that we are going to have a better survival outcome for these patients. So giving these decisions are not easy because the guidelines are limited in some areas that we are trying to get all together. And what we are trying to avoid is the potential biases in our mind that, let's say, if one of our patients had a good experience with one treatment or one other patient had a bad experience with another treatment. So this is called the excessive empiricism or the rationalism that we are trying to avoid while giving these decisions. And not all patients have the same scenario with the same therapy approaches. So this is, as I've mentioned, this is a very heterogeneous disease. So to avoid these kind of biases and try to optimize the best decision for these patients, what we should do is to get all together and ask the meaningful questions related to our specialty and putting the patient values on goals into the center. So what I am trying to say in conclusion is that we are dealing with a very hard, challenging disease, very heterogeneous disease, and the treatment decisions are usually not uniform. And we are trying to protect the liver, and we are trying to ablate the tumor, and we are trying to find the balance to these patients. And we usually, what we are doing best right now is to personalize, individualize our decisions. And how I see the HCC management in the next few years is that probably we're going to see the introduction of the systemic therapy used in different settings, including the neoadjuvant or the downstaging as a downstaging option. And hopefully what I would like to see in the future is that the introduction of the personalized management tools, especially the molecular subclassification of these tools, could potentially reshape our therapeutic decisions, hopefully in the near future. Thank you.
Coşkun, very nicely you summarized the treatment alternatives across different BCRC stages. It was an excellent talk, and you set the stage for further debate. But we will do this with the case after the case discussion because of time constraints. We need to continue with Dr. Golan for the cholangiocarcinoma update. Thank you.
Yeah, so Obviously, the liver meeting historically did not include a lot of biliary tract cancer, cholangiocarcinoma, although very much a reflection of the fact that this is becoming an increasing disease in incidence. We're seeing about 25 to 30 abstracts, and we will be discussing some of these during this update. So there's many ways to look at cholangiocarcinoma. Our medical oncology colleagues who I interact with on a daily basis tend to refer to this as BTC, biliary tract cancer. And I like this because it's a more holistic approach to a cancer that starts in cholangiocytes, and that can be anywhere from the gallbladder. So gallbladder cancer is a specific type of BTC that carries a worse prognosis and certainly has its own implications in terms of molecular genetics, to cancer that arises in the distal column bile duct or the perihilar column bile duct, the so-called Klatskin tumor. And if you combine those two, you would refer to them as ECCA, extrahepatic cholangiocarcinoma. And last but not least, the most common form of biliary tract cancer is intrahepatic cholangiocarcinoma, or iCCA. That, I think, is a fairly good structural way to think about cancer location because it has implications not only on what kind of surgery the patient receives, but also what kind of treatment options are available to them. The other way to look at this is actually about regarding growth patterns. So this really carries more of a diagnostic value than a prognostic value. So it's important to understand that biliary tract cancers typically are trophic to bile ducts, right? So they grow along bile ducts, and when they start growing bigger, they expand centripetally outside of a bile duct. And so some in the parenchyma will form a tumor, that's your classic iCCA. Some will infiltrate the bile duct and cause peribiliary dilation with mass lesion. That's periductal infiltrating pattern. Some will just stick inside the bile duct and just show like almost like a bilioma or a scarred desmoplastic area. That's intraductal growth. And some typically grow out of the bile duct and form mass lesions. This can happen at the hilum, or it can happen further up inside the substance of the liver. Mercifully, both iCCA and ECCA are relatively uncommon cancers. If you actually look at this worldwide assessment based on the IHME database, you can see that clearly iCCA tends to be more common. I think we have some data from Turkey here, which shows that you are somewhere along the middle of the pack, right? The problem with this is that there is a perception that both iCCA and ECCA are increasing in incidence, perhaps driven by increased risk factors, perhaps by other factors we don't fully understand. This is a classic histological specimen of someone who has a Klatskin tumor. You don't need to be a world-class pathologist to identify a mass lesion right at the hilum, which is obstructing and causing upstream biliary dilation. And the classic histological specimen from someone who has a Klatskin tumor is a gland-forming tumor, the classic adenocarcinoma, which you can see here. Sometimes cholangiocarcinomas can have a very vigorous dysplastic reaction where they, desmoplastic reaction where they actually have a lot of scar tissue surrounding them, and this can make it quite challenging to actually diagnose the patient because you might be biopsying scar instead of the actual tumor and may be misled to believe that the patient has a benign process or IgG4-related disease, by itself a whole talk. How do we diagnose cholangiocarcinoma in general? There is obviously not one test that clinches the diagnosis reliably. Certainly it is not CA19-9. If you're going to do one test that reliably makes the diagnosis, that's not the one. As you probably know, 5 to 10% of humans have something called the Lewis phenotype, which basically means that they don't make CA19-9, so they can have widely metastatic BTC and still not make any CA19-9. CA19-9 is a terrible test in terms of positive predictive value. You should never bank on this, for example, for screening purposes. It does have a high positive predictive value if you're CA19-9 and a non-obstructed system. Very important detail is over 100, most of the time you tend to have cholangiocarcinoma. And in general, and this has withstood the test of time, including in the transplant era, if your CA19-9 in a decompressed, non-obstructed system is greater than 300, chances are you have pretty advanced disease and a poor prognosis. Increasingly in the modern era, when you're trying to diagnose cholangiocarcinoma, you're doing an ERCP. And of course, if you find a lesion in the bile duct, specifically in the common bile duct before the bifurcation, that's a very easy one, but often it can be more subtle. And you might require cross-sectional imaging, which here in this particular case of an MRI, basically, again, shows a centripetal lesion around the bile duct, which is classic for cholangiocarcinoma. Extrahepatic cholangiocarcinoma, of course, has more symptoms, which makes it sometimes a more favorable prognosis because you can diagnose it a little bit earlier. The symptoms typically are the onset of jaundice, which more often than not is painless, but can be associated with abdominal pain. Pruritus, which can be very intense. Pale stools, dark urine. If the patient develops cholangitis, they can develop a fever. And of course, one of the cardinal symptoms of cancer in general is fatigue, which certainly happens here. At the liver meeting, there were a few abstracts looking at different aspects of the care of persons who have cholangiocarcinoma. This particular one is from our good friend Lewis Roberts at the Mayo Clinic, and this is basically an analysis of patients historically who were cared for at the Mayo Clinic Rochester, about 609 patients. 320 had cholangiocarcinoma and 289 had HCC. This is not just intellectual curiosity. They're really trying to understand the burden of the disease in terms of how the patients perceive it. And without getting into too much detail, it is interesting that there was better overall quality of life in general in patients who actually had cholangiocarcinoma. But if you look at there were similar quality of life indicators, including this FACT-HEP total between cholangiocarcinoma and HCC. Cholangiocarcinoma patients, though, had a lower physical well-being score. So in general, they tended to not feel as good. They tended to emotionally be more vulnerable. They tended to be less functional. And that certainly is driven very heavily by fatigue and lack of energy. If one looks at symptoms, they're actually quite similar. Pain occurs equally in both cancers. Feeling ill, perhaps more commonly in cholangiocarcinoma, and difficulty of meeting family needs was similar. HCC patients more often reported a history of smoking compared to cholangiocarcinoma, and interestingly, alcohol use, which you would think would probably be more prevalent among patients with HCC, was more prevalent among people who had cholangiocarcinoma. The traditional staging system for cholangiocarcinoma follows the classic TNM style. Stage 2 carcinoma is carcinoma in situ. This is rarely found and is classic of a gallbladder cancer that you discover when you do an incidental cholecystectomy for cholecystitis, right? You don't see that very often. Stage 1 is very early, only in the superficial layers of the biliary tree. Stage 2, you're growing into the tumor wall, but not outside to nearby organs and not to nodes. Stage 3 and stage 4 are typically the stages at which we actually diagnose cholangiocarcinoma, and this includes patients that invade major blood vessels, usually portal vein or branches, or spreads to nearby lymph nodes, and stage 4, of course, is metastatic disease. This is I think, an important study from Asan Medical Center in Korea looking at perioperative prediction of microvascular invasion. This is a group of surgeons. Obviously, surgeons would be at the very most interested in this because they'd like to know whether the patient has macrovascular invasion or not so that they don't operate on a patient who wouldn't benefit. And they did find that a serum CA19-9 greater than 80 carries an odds of 2.68 of actually having macrovascular invasion. Historically, as you know, 3 cm is kind of the sweet spot where we consider transplanting patients, and here they found more than 4 cm as being a predictor of macrovascular invasion. Any cancer in the liver, if you have multiplicity, it's not good, right? I would much rather have one 15 cm lesion than 6 2 cm lesions, right? That's always the case, and not surprisingly here. And the last one, which I think is novel to some extent, is arterial phase peritumoral enhancement. If you actually see not just the tumor itself, but the area around it enhanced in the arterial phase, that actually is a pretty exquisite sign that the patient may have macrovascular invasion. Moving on to treatments for this difficult to treat cancer, depending on the location, one can contemplate different surgical interventions. For intrahepatic cholangiocarcinoma, the time-honored surgery is an R0 resection with typically multilobar and lymph node dissection. We have very good data from an extensive number of case series which shows reliably that your 5-year recurrence-free, even with an R0 resection, is unfortunately around 25%, which means that 75% of patients will recur even in the best of circumstances. If you happen to have a perihilar cholangiocarcinoma, a competent hepatobiliary surgeon will perform either a Whipple or a modified Whipple, and that typically involves a caudate lobe resection, a portohepatis lymph node resection, and there, even in an optimal setting, surgery cures you at 5 years in a minority of patients. And if you happen to have, I'm sorry, that's not true. That distal cholangiocarcinoma, you get a Whipple, and that cures you in about 27 to 37% of the time. And perihilar cholangiocarcinoma is an involved surgery, which includes hepatic or caudate lobe resection and portohepatis lymph node resection, and that also carries roughly around the same 5-year recurrence-free survival. Intrahepatic cholangiocarcinomas, because of their location, tend to be much more difficult to detect from a symptom perspective. They're about 10 to 15% of liver tumors, and they seem to be growing in proportion in terms of all primary liver cancers. Their incidence is increasing globally, and the major risk factors, of course, are primary sclerosing cholangitis, any chronic biliary inflammation related to infection, liver flukes would be a good example, and viral hepatitis is clearly a pretty strong risk factor for intrahepatic cholangiocarcinoma. Cirrhosis obviously increases your risk, and of course, duct plate abnormalities like choledochocysts and others are clearly a risk factor for these. Age and exposure to vinyl chloride like Thorostat, which really does not happen anymore, can certainly expose you to this. But generically speaking, if you look at all patients who have iCCA, the majority of them are sporadic and don't have an established risk factor. For the past about 15 years now, we have contemplated transplantation given the dismal prognosis if you just resect patients or give them systemic therapy. And there's a series for both extrahepatic and intrahepatic cholangiocarcinoma. For extrahepatic cholangiocarcinoma, your series basically show that liver transplant in carefully selected candidates gives you about a 5-year overall survival. On the low end of about 42%, on the longer end, the longer series from Greg Gores and others now at the Mayo Clinic, somewhere around 63% 5-year survival. This, of course, is much better than the alternative, which is basically attempting to resect or provide the systemic therapy. There seems to be clearly a more favorable outcome when you transplant patients if PSC is the etiology versus other etiologies. Intrahepatic cholangiocarcinoma has not been studied as extensively, but certainly is a consideration for many patients. These are all, I would say, relatively small series. Probably the largest one is, I think there's 2 of them, one from Nebraska and one from Mayo Clinic, and those show on the low end a 5-year overall survival of 33%. On the high end from Gonzalo Sapisocian in Toronto, a 5-year overall survival of about 50%. So to sum up, if you do not have metastatic cholangiocarcinoma, if you have locally advanced or local cholangiocarcinoma, Your 5-year overall survival ranges from 50 to 70% for perihilar, somewhere between 60 to 80% for intrahepatic. If you actually do surgery, your 5-year overall survival is somewhere between 30% for perihilar cholangiocarcinoma and about 45% or less for intrahepatic. And if you actually give systemic therapy, we're going to get to that in a second, because the patient cannot tolerate one or the other, your 2-year overall survival declines precipitously down to about 25%. So what is the standard of care for someone who has advanced cancer or cannot tolerate these more aggressive surgical or transplant etiologies? Well, up until 4 years ago, there was only one thing, and that is the ABCO2 regimen of gem-cis, right? Gemcitabine and cisplatinum. You get 8 cycles of that. This is the landmark paper, which was published almost 10 years ago, which established this. Your overall survival, which you may not be able to read, but I'll read it for you, is 11.7 months. That's dismally low, and that actually includes a fair amount of toxicity because you're giving cytotoxic chemotherapy. In the last 3 years, we've had the approval of 2 regimens, one based with durvalumab and the other based with pembrolizumab. This is based on the Topaz-1 and the Keynote 966 studies, and these are almost like Coke and Pepsi. You could extrapolate them completely because they show exactly the same data. Your median overall survival is now about 13 months, and that includes a hazard ratio of 0.74 for reducing death. And your side effect profile is much improved compared to cytotoxic chemotherapy, which is why this has become the standard of care. So you pick your immunotherapy of choice, pembro or durva, and pair it with gem-cis and give that for maintenance up to 2 years, and that's pretty much what medical oncologists do for advanced cholangiocarcinoma today. Your dropout rate obviously is significant if you give the ABCO2 regimen. Your dropout rate for Topaz is about 9%, and your dropout rate for Keynote, which primarily relies mostly on the combination of gem and cis, is 19% versus 3% alone for discontinuation of all study drugs. So you can always stop one drug and continue to give the 2 others. At the liver meeting, there was a nice review of the patient characteristics and treatment patterns among patients with intrahepatic cholangiocarcinoma. Basically, this recaps many of the themes that I'm going to reiterate later, in that the most common genetic alterations include FGFR2 and IDH1. Cholangiocarcinoma is a disease where actionable mutations are quite common. Autoimmune comorbidities were very common in these patients. Durva gem-cis was received by 21% of patients, and gem-cis alone by 35%, and this actually is a byproduct of the timeline when durva gem-cis was approved. And many of the patients with autoimmune comorbidities tended to actually be able to receive durva, which one might think might be an impediment. So the last 2 points I'd like to make in this review is that there is no poster child for genetic alterations that are potentially druggable more than cholangiocarcinoma. This is a disease where next-generation sequencing is mandatory. This is not an optional thing to do. Every patient should have next-generation sequencing, and in some cases more than just that. I'll get to that in a second. If you look at the most common molecular alterations, these include IDH1 mutations, that's about 20%, FGFR2 mutations, about 10%, HER2 mutations, about 5%, and BRAF, about 3%. Why do you even test for these? Because every single one of these has either one or multiple drugs that you can actually prescribe the patient. I don't know about in Turkey, but in the US at least that is indeed the case, and I'm sure sooner or later these treatments will become available everywhere. There's also an interesting detail about this, in that specific locations along the biliary tree, for some reason, actually carry different genetic mutations. For example, if you happen to have gallbladder cancer, you're much more likely to have a KRAS or an ERB mutation, whereas if you have intrahepatic cholangiocarcinoma, you get more of the traditional mutations that we talked about, and extrahepatics tend to also have very specific ones, including SMAD4 and CDN. It's important when ordering next-generation sequencing to understand that it does not pick up all of these. There are some tests that require RNA sequencing. For example, FGFR2 mutations are fusions, and you need to order RNA sequencing. In the US, the companies that do this will do that for you by default. HER2 amplification requires FISH and IHC. So there are some of these that you don't just order a test based on tissue, you actually have to order additional testing for. And why would you do this? Because as I mentioned, every one of these actually has a specific treatment. For example, if you happen to have a mutation of FGFR3, there's a pill called futibatinib that you could actually get that would increase your likelihood of treatment. You do not do this up front. You only do this in second line. First line is always durvalumab or pembrolizumab. This is only in second line in patients who don't respond. In the case of patients who have IDH1 mutations, ivosidenib is an FDA-approved treatment. And of course, broadly speaking, pembro and durva are the standard of care. So putting it all together, in the early stage, there's a lot of things you can potentially contemplate. This includes transplantation. This includes monitoring patients and potentially considering them for systemic therapy if they do not respond. If the patient has locally advanced disease, you automatically want to do molecular profiling so that you can decide on what your second-line treatment is. And if they have advanced or metastatic disease, you also want to do that and initiate the first-line therapy with an immune checkpoint inhibitor with GemCis. And then once the patient progresses, you pick the mutation that appears to be driving the cancer and you target the treatment. So the ultimate, really, expression of personalized medicine, if you want to think about it in that particular situation. I don't have too much time to talk about this, but CAR-T, adoptive cell therapies, cytokine therapies, and a number of bifunctional, bifusional proteins. So this includes bispecifics, which is the big revolution in cancer now, are the future of cholangiocarcinoma treatment. I'm going to stop here and thank you for your attention. And I don't know if we have time to take questions.
Dr. Golam, thank you for the comprehensive review. We have time limitation, but we can have one question from the audience, if there is any. If not, I can make a brief comment. You showed data from Asan Medical Center, Korea, on cholangiocarcinoma surgery. Actually, Korea and Japan are the most aggressive countries in the world doing aggressive cholangiocarcinoma surgical treatment. And the results, like it had been for gastric cancer, the difference between the West and the East is striking. What we have observed for gastric cancer, now we are observing for cholangiocarcinoma, as you have shown the Western data showing about 30% 5-year survival, and the Eastern data shows more than 40 up to 50% 5-year survival. So from a gastroenterologist standpoint, would you elaborate on this, please?
So I think Asan Medical Center is a very bad example to give, in my opinion, because that is the mecca of hepatobiliary surgery and transplant. That's a place that's been doing 400 transplants a year for 15 years, right?
Yeah.
I say that tongue-in-cheek, of course. So that is a place where there's a very high level of expertise at doing this. I would say that since the Wisconsin series almost 15 years ago now, the needle has moved very slowly on the recurrence-free survival after surgery. Certainly that is the case for intrahepatic cholangiocarcinoma. I don't doubt that refinements like being able to better guesstimate who gets macrovascular invasion will push this up. And there certainly is a very robust role for surgery. But I don't think that that's going to be the solution in the end. At least that's my guesstimate at this point.
Okay, thank you.
Yep.
We move on to the next session.
Yeah, and now we have two very interesting cases. The first one is from Genco Gençdal. And we would like to have this session in interactive mode, especially we want our speakers to comment on the cases Professor Golam and Professor Demirtaş. Please feel free to comment whenever you want to comment. And also, if you have any questions, please come to the microphone and ask your question directly. Yes, move on, gençler.
Okay. Firstly, I'm very grateful to organizing committee and session chairs and participants for their interest on our case and also facilitating this panel. Our report is about a 70-year-old male, patient admitted for evaluation treatment, hepatic lesions, detected during the routine follow-up, no acute symptoms at presentation. The patient had type 2 diabetes, hypertension, and MASH, and also had a history of RCC surgery at 2080. Family history unremarkable. Medications are metformin, teoxacid, rosuvastatin, vitamin B12, amlodipine, valsartan, insulin glargine, carvedilol, no known drug allergies. Laboratory findings was approximately normal albumin level is normal, INR is normal, but AFP slightly high, and total bilirubin slightly above the normal values, and creatine levels normal, platelets at 134. We have an MRI, and at 2022, there were LIRADS 5 lesions at segment 8, primary lesion approximately 40 millimeter, and at segment 2, we have another 2 adjacent nodules with a diameter of 10 and 11 millimeter, and also we had additional lesions, LIRADS 4 category, a multifocal HCC.
And
what's your opinion for next step?
Can you go
Yeah.
back, please? At this stage, 70 years old male patient,
Yeah.
The liver is preserved, albumin levels are, INR levels are
Child A,
normal.
yeah.
We don't have documented cirrhosis, but platelet levels are a bit low, slightly high AFP levels, and history of RCC,
Yeah.
renal cell carcinoma. Is
True.
this a typical lesion, Bora? We know that RCC has hypervascular metastasis to liver. Do you ask for biopsy at this stage, or are you sure with the ACC?
I mean, the team didn't really want to ask it, but this is a good question, actually. We just see 2 images from the biggest lesion at the dome, at segment 8, I believe. So what we see here, the arterial phase on your left, and the venous phase, I think slightly delayed phase on the right. So it's a complete washout, almost complete, I would say, except for the anterior part of the lesion. So this is a typical LIRADS 5 lesion, which means that it's a typical for ACC. RCCs can enlarge in the arterial phase, but never wash out like this in the ACC. But we have to know the exact phases of the MRI for sure, of course. But there are smaller lesions, LIRADS 4 categorized, so it must be a multinodular HCC, I believe. Yeah.
So
Thank you.
these are ACC lesions. So are we in Milan? Do you transplant, or are we out of Milan? Do you transplant this patient, Deniz? How old was he?
What?
70.
How old was the patient?
70 patient, 70 years old.
70
Yeah.
years old. So there was a question yesterday, do we transplant over 70 or not? So let's
So
have it from...
when the patients ask me, do we transplant or not, in Turkey, I think we have to look at the data. What is the life expectancy of average man and woman in Turkey? And recently it is improving. For male, it went up to 78. For female, even more than 80. Could be, so we should, I think now it is time to discuss in well-selected, biologically and with cardiopulmonary reserve to transplant those patients. And in practice, in well-selected patients, we are transplanting and resecting those patients. Resection can even go up to 80. Transplantation, we stop somewhere between 70 to 75.
Professor Golam has...
Yeah, I just want to make a quick point. So if a patient has cirrhosis and has features of APHE, arterial phase hyperenhancement, It is typically not, unless you're doing a research study or planning to actually do next generation sequencing, it's not typically the norm to biopsy these patients. Our societies endorse not doing that. But most people would biopsy a patient even when they have APHE if they have a known primary. I think a known primary, we've been bitten many times by patients who have a known primary who end up having metastatic disease that looks exactly like HCC. RCC is actually one of the common culprits for that.
And also sometimes we do taste, tear, and we know that when we do taste, tear, HCC reoccurs. And sometimes we find ourselves that 4 years past, we do lots of things, but we don't have the pathology results. So sometimes for that reason, we discuss in the tumor boards and we try to do the biopsy if we are not going to resect. If we have going to resect, then we got the pathology. That's okay, but if we don't resect, we ask ourselves to do biopsy or not for that reason as well. So from other centers, we have transplant centers, surgeons from transplant center. Yeah, Murat.
So the first two questions should be, is the patient transplantable in terms of performance status? And the next question should be, does the patient have a potential donor? But this is especially for our environment in Turkey. So these two questions will direct the further treatment, the further steps. If the patient is transplantable and he has a potential live donor, then we would proceed with the transplant, of course, because there are multiple tumors. AFP is just 14, and there is no portal vein invasion. So, of course, the choice would be transplant.
Okay. Let's see what's done in your center, Genco.
Yeah. Testes or? Okay. We have selected surgery. Surgery and also think for resection, but in intraoperative ultrasonography was performed with radiology specialist consultation, cirrhotic liver and mixed echogenicity. Laparoscopic RF radiofrequency ablation is selected for segment 2 lesions. And then, following the radiofrequency ablation, at September 2022, do you have a question? What?
There is no tumor in the outside of the liver?
No tumor. Yeah. Yeah, only multifocal HCC, not distributed to other place. Yeah. And also we have following first tear, segment 8 lesion, successful mapping and no complications occurred. How would you follow up this patient?
What was the real procedure during the surgery? It was just a biopsy and the laparoscopic RFA only, or did they do the resection for some lesions?
No. They performed the surgery and consulted the radiology specialist, and they only radiofrequency ablation.
So no resection, no biopsy,
yeah?
right? No resection, no
No
biopsy.
No resection. No resection. Biopsy was, I think, with HCC. Yeah. Okay.
After tear, Bora.
We have to follow the patient up for sure for this particular patient as well. So what we do after radioembolization, we do the 6 weeks follow-up with MRI in general, and see the patients, they see the lesions, and then decide what to do for the next step. And of course, including the liver function test and everything.
Yeah, we have follow up the patient with the AFP and MRI, and also medical oncology. I also look at the medical oncology notes. They have started the sorafenib for this patient. At MRI,
Microphone.
yeah. After follow, but when they start, I don't know, but I saw from the notes. Generally, we decide, we give the decisions with the multidisciplinary council. So according to the council following decision, they have started during this follow-up.
So the idea is you're starting sorafenib as adjuvant therapy. Is that what you're referring to?
Yeah.
So there's a study called STORM, which was done, which we participated in almost 11 years ago, that showed that sorafenib was not effective adjuvant therapy for
This.
HCC with an intent to cure. So that certainly would not be the standard. Now, individualized therapy would certainly be something that's weighed into here, but that would not be what most people would do. I would just leave it at that.
Okay,
yeah.
thank you.
Coşkun?
So, trying to understand the intention here, because there were multiple nodules in the segment 8, so that we thought that if we could direct segment 8 with TARE, and we did a radiation segmentectomy, and for the lesion in segment 2, we performed ablation. But we did not choose a percutaneous ablation in the surgery because it was not reachable with the percutaneous approach, or you choose the resection with the intention of resecting both segment 8 on the other segment. That's the point I was confused and I wanted to ask.
That's a good point, but there was no resection. There was only laparoscopic ablation.
Ablation, yeah.
Because it was not reachable with the percutaneous route.
No resection is performed only during the surgery. They have consulted the radiology specialist and looked at the lesions.
Because they couldn't see it on the
ablation.
ultrasound and they thought that percutaneous access is not possible.
Yeah.
So would you consider SBRT in this condition instead of, it was a very small lesion, would you combine TARE with SBRT targeting segment 2 instead of sending this patient to a surgical ablation intent?
Maybe we can try, but according to center's experience, I think.
Murat?
I wonder who decided to do this treatment. Was the decision taken during the multidisciplinary discussions?
Yeah. Multidisciplinary council.
But this is not an educated decision. It's against the guidelines.
According to 2022, in surgery, after surgery, maybe they have decided this.
But the decision to resect this tumor was also against the guidelines.
Maybe multifocal and also bilorbar and also the additional LIRADS4 lesions.
So
Probably they started to, the first decision was resection, and during the surgery, resection was not feasible, and then they returned to do RF to the small lesions, and then additional tear was performed, and because of residual tumor suspicion, they add TKI or something like things happen sometimes in
But
real
this is
world.
an example for bad decision making. This is just a weird case.
Firstly,
move on. Let's
they
move
have an idea for resection, but maybe in operation they have another decision. And done this. MRI follow-up at 2023. The liver counter-demonstration lobulation and parenchyma appears heterogeneous. At dome level, segment 8, the previous treated tear lesion is identified and measuring 41 millimeter, and 11 millimeter satellite nodule is present adjacent to this lesion. In the early arterial phase, no enhancement suggestive of viable tumor tissue is observed, and hemorrhagic signal characteristics are noted with the lesion. The lesion is the lateral segment of the left lobe, were also previously treated. However, at segment 3, an approximately 8 millimeter lesion observed, showing arterial phase hyperensacement, washout in the delayed phase, and appearing hypointest on the hepatobiliary phase. Also, then at March 2024, albumin level was normal, total bilirubin level was normal, but AFP increased, 42. Creatine level is slightly high. INR is normal, platelets were normal. No contrast enhancement suggestive of local tumor recurrence was detected in the ablation area segment 8. However, an increase in the size and the number of Lirat's category 4 lesions in the liver was observed adjacent to these lesions in other segments. What's your opinion for next step?
Genco, winter is coming, but let's ask Bora how he would comment on this.
Now, 72.
Yes, Bora.
So is he still on TKI, the sorafenib, during this follow-up?
Now, during this follow-up, I looked from the medical oncology notes. They have also used the atezo and beva treatment for above 10 seconds, and then they have an epistaxis, so they stopped it, and next level, they choose the immunotherapy.
So can you go back, please, with your slides?
Yeah.
So at what point do you think they switched to the atezolizumab? That's
2024, after this,
this March 2024?
no,
Or the one before?
at the end of the 2024.
Not with Atevobeva at this moment.
Yeah, okay.
Or after this MRI, and I will also. Okay. Okay, continue. We have performed radioembolization, 2 branches of right hepatic artery catheterized, and segment 6 and segment 8 lesions. Therasphere was used. No pre-procedural complications occurred.
I'm sorry, I'm a little confused. So they started atezo-bev, and then the patient had epistaxis, and they couldn't tolerate
Yeah.
bev.
Yeah.
So they switched to different immunotherapy? They switched to durvalumab or
They
to
switched to different immunotherapies, I
immunotherapy?
heard.
Okay.
Yeah.
And then where does the local regional therapy come after that? They did local regional.
First, I think they do this and then start the systemic therapy.
Okay, okay.
Yeah.
So first they attempted to do local regional therapy
Yeah.
of the recurrent lesion after 2 years after ablation.
Really, I think they have a decision about the tumor biology is very aggressive.
Right.
Yeah.
Very unusual sequence of events. I've never seen a sequence of events like this, but as long as they started immunotherapy after they did the radioembolization, I think that would make logical sense, sure.
Devam edelim. At MRI at 2025, there is a marked increase in the size number of masses surrounding the ablation zone, and the current examination with conglomeration, as well as newly developed intravascular thrombus, tumor thrombus with the right portal vein. These findings are corresponding to LR progression and tumor in vein according to Lirat's. Now we are following the patient with hepatology and the medical oncology outpatient clinics. Yes, still alive.
So, before moving on to the next session, I would like to comment that it was surprising to hear from Dr. Golam. 1 in 10 patients in the United States is having an optimal surveillance and follow-up with this. I think we are a little bit more lucky in Turkey, patients having universal health care and have access to state-of-art imaging. Anytime a physician considers that it is necessary, like a dynamic CT scan or MRI scan, which also includes PET scans. So in this regard, I think this patient have, from the surgical standpoint, like what Murat said, is undertreated. The first surgery could be planned, good old resection, will solve the problems in the right lobe. You can still ablate the left lobe if you, as a center, don't provide transplant as a treatment option for the patient. And then we see the natural course of HCC taking its action. So thank you, Genco.
Thank you very much.
And can we have the next case, Özge Koç? Yes. Stage is yours, Özge.
Dear Chairman, professors and colleagues, good day everyone, and thank you for joining this multidisciplinary case discussion here. Today I'm going to present a diagnostically challenging case with a hepatitis B. Our patient is 76 years old male. He He doesn't have any complaints, but an incidental liver lesion was detected routine surveillance. He was followed up for chronic hepatitis B, which was diagnosed in 2006, and he was on tenofovir alafenamide for hepatitis B. He had also grade 4 chronic kidney disease and hypertension, no liver disease in the family. At presentation, the patient appeared clinically stable, and there were no remarkable findings in the physical examination. As you can see here at the baseline evaluation, he had preserved liver function, and the patient had ECOG performance status of 1, but you can see here the alpha-fetoprotein level was elevated. So due to elevated AFP level, we performed a multiphasic liver CT, and it demonstrated a 3 centimeters hypodense lesion in the left hepatic lobe without characteristic enhancement. The lesion was indeterminate, so further imaging was warranted. And also you can see here, there was a heterogeneously enhancing subcapsular lesion in the left lobe with mild capsular retraction.
Yes, Bora, would you comment on this?
Yes, actually, the first question is why did you prefer CT over MRI? Did the patient have any claustrophobia or something like that?
No, we performed MRI later on because due to chronic kidney disease, we could not perform a contrasted MRI, so we performed CT first.
I mean, the reason you're avoiding using MRI contrast was for
CKD.
nephrogenic
Yeah.
stem fiber, but which is not a case in terms of the cyclic agents. So I think it's the best way to go with the cyclic MRI agents and MRI with this kind of impaired renal, functions. So what I would say for this MRI, is for the CT, sorry, as you said, it's a I would say mixed washout in this tumor, and there's small peritumoral enhancement at the beginning in the arterial phase. It's, I believe, like 3 centimeter, 3.5 centimeter lesion maybe, and we see just a single lesion here.
Following CT scan, we performed a non-contrast MRI. As I said before, due to chronic kidney disease, contrast could not be administered at that time, and this limited our ability to fully characterize the lesion, but MRI revealed a 3.5 centimeter subcapsular lesion with diffusion restriction, so it was categorized as LIRADS M.
So again, yeah, this is a T2 signal, hyperintense lesion, and in the diffusion, the DVI sequences, you see the diffusion restriction here, and in the mapping, ADC mapping, it's hypointense. There's no contrast here, so what we can say, this is a lesion, but we cannot characterize it, appropriately in this MRI.
So what do you recommend, Bora, in
A
this?
contrast-enhanced MRI, preferably hepatospecific agent, which
GFR is less than 30.
doesn't make any.
Okay.
I think, as was pointed out, the concern for nephrogenic systemic sclerosis with cyclical agents we do not ever really raise that. I'm sure there are radiologists in the room who know more about this than I do. We don't really ever get concerned about that anymore.
That's the same in the radiology area as well.
At this point, we wanted to rule out extrahepatic disease, so we ordered a thoracic CT, and this revealed no intrathoracic metastatic disease. He had also some bilateral pulmonary nodules smaller than 6 millimeters. And PET-CT showed hypermetabolic mass in the left hepatic lobe. It had heterogeneous FDG uptake with internal hypermetabolic areas. Other than that, no additional pathological FDG uptake was detected. So to sum up, what do we have so far? We have 76-year-old male patient with ECOG performance status of 1 with preserved liver function, and he has compensated advanced chronic liver disease due to hepatitis B. And we have a subcapsular lesion suspicious for primary hepatic malignancy without extrahepatic spread.
What to do, Deniz? What you do for this patient? What's your plan? Do you transplant? This is even older. This patient is even older with GFR less than 30.
Thank you. I feel very privileged here. Surgeons generally are not the first persons that you ask the opinion. So I think this patient deserves a multidisciplinary team discussion. It is, the patient needs to be evaluated by the team, and performance status is very important. Of course, we would not want to direct a patient to a treatment that the patient will, the procedure will be successful, but the patient will not gain any life years benefit out of the procedure. So in this regard, I think it is a bit early to say transplant or resection yet.
If the patient is younger, less than 70, let's imagine, GFR is 30, do you transplant?
I would resect easily with laparoscopy. This is a very easily accessible lesion with laparoscopy first. Laparoscopy is very well tolerated in older patients, second, and kidney dysfunction is not a contraindication in the perioperative period.
Where is Alp? I mean, the transplant hepatologist with Deniz. Do you let him to transplant if GFR is less than 30? Or do you ask for double transplant? Or what's the hassle you got if he transplant a patient with kidney disease?
I think this is a resectable lesion, so that's why we should recommend to patient surgical resection. It's early for transplantation, I think.
But if he do, I mean, if it's a larger lesion, but in Milan, if he tries to do the transplant with GFR 30, less than 30, what obstacles do you have afterwards? How do you manage the patient?
If it is unresectable and so it's in the Milan criteria, so we recommend transplantation for this patient. The GFR less than 30 is not a contraindication for liver transplantation. So maybe some partial or full recovery of the liver kidney function we see after transplantation.
Okay. Any comments?
So I may have missed it, but do we have histology on this patient? Do we know what this lesion is?
No.
So it is not a lesion that meets APHE criteria. Therefore, we have not established the diagnosis. So typically the workup would include a metastatic workup. You did a CT scan of the chest. We do an uncontrasted CT chest. And a pan endoscopy to rule out luminal GI malignancy, although this doesn't look like a typical hypodense met in the liver from colon cancer or something, but that's typically part of the...
We are not sure with the HCC at the moment, but we got the PET results. With the PET results, we assume that we don't have any extrahepatic lesion, but we are not sure, of course.
Right, exactly, yeah.
I was actually going to point out the same thing, but when we have a chronic hepatitis B or when we have cirrhosis and when we have the radiologist pointing out that this is LIRADS 4 or 5, then we don't need biopsy. But instead, we still have chronic hepatitis B, but it's an intermediate lesion that we do not know before going into the transplantation resection decision. This is the case that we need to have a biopsy.
Even if this is a primary liver lesion, this is not typical for HCC. FDG avidity is too high, and both CT and MRI are not typical for HCC. So this patient should be evaluated with biopsy, definitely.
What did you do, Özge?
Okay, we evaluated this patient in the multidisciplinary team meeting, and as you mentioned before, high FDG uptake on PET raised suspicion for cholangiocarcinoma. And based on the radiological findings, surgical resection was recommended both for diagnostic and therapeutical purposes. Unfortunately, a patient was lost to follow-up, and we did not hear from him again until January 2025. Okay, at representation, clinical and radiological assessments was once more performed. He had still ECOG performance status of 1 and preserved liver function, but AFP level had significantly risen to 789. So now this time we performed a contrast enhanced dynamic liver MRI, and it demonstrated significant interval size increase of the lesion, and now the lesion was 7 centimeters. And it also demonstrated mixed enhancement pattern, which was suspicious for a combination of combined HCC and CCA.
So yeah, what we see here in the below part actually, this is a huge lesion, a 7 centimeter. There's a mixed contrast enhancement. In the early phase, most of the lesions is getting the contrast. And the delayed phase, it's still, the contrast is still there. It's not washing out, but there are some parts that are not getting the contrast as the other parts. So it's not typical for HCC. This is most likely a cholangio as a diagnosis for the MRI.
Can you go back? What was the AFP and CA? Yeah.
CA 99 level 1 was normal, AFP level was over 700.
Okay.
PET-CT showed further metabolic progression, but patient had still no extrahepatic disease. So what would be the treatment options now?
Yeah, Dennis. You recommended surgery, but there is a recurrence.
I recommended surgery. The patient is lost to follow-up. So now I don't recommend transplantation with high AFP. We know the recurrence risk is very high. But still, the surgical resection can be an option, or in a multidisciplinary discussion setting, I think our colleagues from oncology would recommend chemoimmunotherapy for this patient right now.
I think a biopsy would still be valuable because there's a potential for mixed tumor, which would be very different treatment, of course, and so we certainly would have recommended a biopsy if we had presented the patient at our multidisciplinary team.
Yeah, biopsies would be the way to go, obviously, but what kind of tumor would you expect with a very high AFP component and low, still high, but low and high with CA19-9 component?
So mixed
Yeah,
cholangiocarcinoma.
it will be a mixed tumor.
Right,
So
right.
I think further characterization could only come from genetic profiling. I don't know if there's hard data showing benefit of one immunotherapy over another one in mixed tumors.
So in mixed tumors, we treat them as cholangiocarcinoma.
Yeah.
We don't treat them as H. So there is some therapeutic, there's a fork in the road in terms of which therapy you would choose, one versus the other. So if a patient had just a cholangiocarcinoma, A, prognosis is going to be much worse, and B, you would actually give them pembrolizumab or durvalumab as opposed to giving them, let's say, atezobev or durvalumab or, right?
How about local regional therapies? We don't know we are not sure about HCC or cholangiocarcinoma at this point. And
yeah, once we clear the diagnosis, of course, we can do a local regional therapy because there's no sign of extrahepatic disease at this point. So this patient would benefit from, I believe, a Y90 treatment. Yeah.
if it's cholangiocarcinoma, do you change the treatment modality?
I mean, if it's definitely need a systemic therapy for the cholangio first, and then but we still can do the radioembolization as well. Yeah.
So we send the patient to you to do the biopsy, and at the same time you do the TACE or TAIR.
Once we get the results, we can discuss again at the tumor board, and yeah.
Okay.
Ramazan İlman.
Thank you very much. I mean, for staging of the HCC, different to these cases, what ASRD guidelines say that? I mean, is something wrong in Turkey? Because we checked the PET-CT, and if PET-CT negative, that means no HCC outside of the liver. I think it's something wrong going on.
Right. So ASLD has guidelines for non-invasive diagnosis of HCC, which are also adopted by EASL and APOSL. And they basically revolve around the presence of arterial phase hyperenhancement in a patient who has cirrhosis. They have to have cirrhosis. Or you could apply the same criteria for patients who have hepatitis B with a high, what's it called? There's a prognostic score. It has to be greater than 7 in order for you to apply it. In a patient who does not have cirrhosis, even if you have APHE, you have not made a diagnosis of HCC, and it is recommended to biopsy. not codified in the AASLD guidance. If you have a prior primary, like RCC, colon cancer, whatever, it pretty much is mandatory to biopsy that patient. You should not leave it to chance that the patient has HCC. And then staging is a combination of clinical gestalt, imaging, and also, of course, at times made definitively at the time of surgery. We don't ever order PET scans if we suspect specifically HCC because it is not a PET avid tumor usually, so it doesn't really play a big role in staging. Yeah. Every patient who has a diagnosis of suspected of having HCC should have dynamic imaging of their liver and a non-enhanced, do not need to do an enhanced contrast chest CT, but they should have a one-time chest CT. Our society's guidelines do not recommend doing bone series imaging or MRIs of the brain because the risk of METs is very low. That's only symptom-driven testing. Right.
Dr. Günshan.
Thank you for your presentation. I want to ask to the radiologist colleagues, in the first time they detect the lesion, it is 3.5 centimeter. Although it is more than 3 centimeter, in that phase, do you recommend the RF therapy, radiofrequency ablation, and the biopsy? Sometimes our radiologists do this in the same time. The tumor board suggests the surgery, but I understand she doesn't take...
No, not yet.
Maybe radiofrequency ablation and liver biopsy at the first time of the tumor detected, it will be better prognosis. But now, in this phase, maybe the TARE, maybe.
Yeah, I agree with your comment. I mean, if the patient was 76 years old, right?
Yeah.
So he's going to be, avoiding from the surgery most likely at the beginning. So we can offer the ablation plus biopsy plus ablation for sure to begin with. But I mean, the location of the tumor is very favorable for the surgical resection and the excisional biopsy at the same time. So I agree with the tumor board for the first diagnosis, but if the patient is avoiding in such aggressive treatment, then we can move to the ablation biopsy together.
When the second time the patient comes, he didn't choose the surgery, he went away. But when we have this patient at this moment, we don't have the histology. When I send you the patient, I want you to do the biopsy and TASE or TARE at the same time to not miss the patient. But if the biopsy comes with colon cancer metastasis, are we doing good or doing bad? For example, it's not HCC, it's not cholangiocarcinoma, metastasis of colon, for example. Did we do a good thing to this patient or a bad thing?
No, I mean, when we do say about ablation plus biopsy together, we always do the biopsy first, wait for the result, and then do the ablation or whatever we do after. So we tend to wait for the result for the biopsy every time, yeah.
I mean, if a patient truly has cholangiocarcinoma, they have ICCA, ablative therapy is usually not recommended if the lesion is greater than 3 cm. The likelihood of achieving tumor control is quite low. There's a number of case series that reflect this. Now this, I fully understand, because we do this all the time, that this has to do with the patients. You have to meet the patient where they are. This obviously is not a patient who has optimal access to care, not because of anything you're doing, but because, they disappeared for 5 months after their initial. So perhaps doing a one-stop shop may not be a bad idea. I'm just saying, generally speaking, if you have ICCA and you're greater than 3 cm in diameter, ablative therapy and local regional therapy is not going to be an optimal treatment for you. So.
And further to that, this lesion is under the liver capsula. We know that the lesions under the liver capsula do not burn well with whatever ablative methodology. And I think it was a very relevant question from Levent, if it was a colorectal cancer that it come up, would radioembolization would be a good option? And I agree with Bora that we have to wait for the biopsy result. because a recent meta-analysis of 3 randomized controlled trials for radioembolization for colorectal cancer was negative, so it doesn't have survival benefit in colorectal liver mets.
If we were sure about cholangiocarcinoma, shall we biopsy it, Deniz? Do you want us to biopsy if it's intrahepatic cholangiocarcinoma, periductal cholangiocarcinoma, perihilar cholangiocarcinoma? Do you want biopsy?
For perihilar,
Percutaneous.
for perihilar, definitely not. For intrahepatic, if resectable, you have the best biopsy. If not resectable and you need to go for downstaging, then biopsy for chemotherapy.
Yes, Murat.
I would also bring forward the issue of miscommunication with the patient here. If you offer just surgery as a standard of care to the patient and the patient is afraid of this treatment, there should be the second line. What if the patient doesn't want to go to surgeon? Then we should be offering another treatment. If the patient doesn't want surgery, then we should be offering the next best treatment as well. Sometimes we miss this issue and the patients are lost to follow-up.
Yeah, good point. Could you move on, please?
Yeah. Given the absence of extrahepatic disease and preserved liver function and the patient's performance status, MDT decided on surgical resection once more. And pre-operative evaluation revealed no gastric esophageal varices and no portal hypertensive gastropathy, and patient also did not have any splenomegaly. And liver volumes were optimal for resection, so a left lateral segmentectomy was performed. And the pathology confirmed combined hepatocellular cholangiocarcinoma. The tumor size was 7.5 centimeters with satellite nodule and lymphovascular invasion presence, and the surgical margins were negative. You can see here the biphenotypic differentiation and also here in high power examination, and it was, okay. Patient was lost to follow-up again, once more. The first time we could evaluate him was the 4th post-operative month. Fortunately, the patient had no complaints with no decompensation after the surgery, but he did not receive any adjuvant chemotherapy. But as you can see, the liver functions are still preserved, but the alpha-fetoprotein is over 6,000 now. Once more, we performed a multiphasic liver CT, and we show multiple new hypodense lesions in the liver, which were evaluated as early recurrence of the disease. Thank you.
Thank you very much. Last comment from Professor Golam. Do you give chemotherapy to 76 years old?
Absolutely, yes. I would give this person pembrolizumab or durvalumab. I would also, at the time of biopsy, do next-generation sequencing and RNA analysis to make sure that I can identify either an IDH1 or an FGFR2 mutation, because second-line therapy is actually very productive if that's the case. I just want to make one last point. I don't want to delay everyone. So never bank on lack of elevated CA19-9 to exclude a mixed cholangio or even just a plain cholangio. These tumors often have one dominant tumor marker that goes up, but that does not mean that that is how you should be treating the patient. Like, you would be tempted to say, well, the AFP is 6,000, I'm going to treat this patient like they have HCC. You should always go by the histology, not by the differential breakdown of tumor markers.
Thank you. We would like to thank everybody, the audience, because the interactive, also we would like to thank all our speakers for very nice presentations. And yes, Professor Edelman is saying that you have time to have lunch.
Until 2 p.m.
2 p.m. We will be here starting the next session. Professor.